Thank you very much to TVS for inviting me to speak at this conference. My role is, I'm a nurse by background, I'm a non-medical prescriber, I'm still actively see patients, but I also lead on the education and research in Wales around lymphedema and chronic edema. So what I'm going to present to you is something that I presented in BLS last year, the development of a chronic edema wet leg pathway. If the buttons work. There we are. Okay, so what's the problem? This might not be a problem in England, but I think it might be. It's very much a problem in Wales. I created with Lymphoedema Network Wales some accredited units on the management of chronic edema because we were seeing referrals of patients quite late who'd been leaking for quite a period of time, who'd had superficial wounds that eventually, if they're not managed, will become complex wounds. And we just felt it wasn't good enough, really. So, to be fair, people weren't aware of what direction to go with these patients. So, there is the issue around non-concordance, not going to bed, all those things that patients choose not to do for their reasons, whatever their agenda is, whatever they choose to do that. But that doesn't help the district nurses mopping up on the ground. So I was a community nurse for quite a period of time and I felt quite frustrated. I have wrapped Ganji around legs in the previous because that's what I did, that's what we all did, that's what I knew I could do. So when I created the chronic edema education unit, I thought, great, the nurses can come, they can learn about managing chronic edema, we can give them some advice and support, job done. But what happened? Nobody came. Nobody came because you can't be released from work. There's no time. You're seeing all those patients, and you just can't be released. So even though people are keen to learn and know what to do, they're not released to learn about it. So those of you who know me, no doesn't mean no, it means next opportunity. So that didn't work, so what else can we do? Okay, well, we'll go and see them then. So we applied to a fund called the Health Technology Fund. You have to incorporate technology within your bid. So we thought, okay, we can do a patient story as a form of teaching. We can go out to the district nurses and work with them and look at what they see on a day-to-day basis, look at the challenges that they have, but deliver education on the ground with them. So that's what we did. We created a new education model. We said that we would spend at least 2 days with each nurse in a health board in Wales. We would use the patient story as a form of training. We had a little bit of support from industry because we wanted to collect quality of life, we wanted some health economics data, we wanted focus groups with the nurses, because it's all well and good me telling you how great it was, but we wanted to know how they felt it was. Did it challenge them? Did it feel uncomfortable that we were with them? Did they value that we were with them? So we tried to capture as much information as we could. So we had 2 on-the-ground educators, and they were employed for 9 months. So the aim of the project was to raise awareness and identify patients early. The kind of comments that we had, which I'll talk about a little bit later, is they'd be going into a patient and they're given a B12 injection, and they've been on their caseload for quite a period of time. We all know that the longer patients live, that not always the case, but the more comorbidities they have, the less they move, the muscle pump action is less, so edema is going to be a problem for these patients. So the sooner we can identify that proactively, rather than waiting for something to happen, then that's better for those patients. You empower them to take responsibility as best you can, but you're not dealing with the complexities, you're dealing with an intact leg. So I'm really, really excited about the Legs That Matter campaign, Legs Matter, because it's part of what we identified as this. So the other thing was to deliver the education and to treat the wet legs there and then, reduce waste, harm and variation. So we did qualitative and quantitative research. We only had a purposive sample of 100, but we wanted to look at the data. We wanted to look at where the patient had been for 3 months, our intervention, whatever that would be, and then what happened to them after 3 months of that intervention. We did quality of life, we did health economics, we did focus groups with the nurses, and we had ethical approval from Swansea University. So there we are with our cases. Patients asked us if we were going on holiday. Were we going to do their hair? What were we there for? But we tried to put everything we needed in the case so that when we saw the patient for the first time with a district nurse, we could actively treat them there and then. do an assessment if there wasn't enough time, because some of these nurses are doing 14 calls a day. Staff that work in Lymphoedema Network Wales who see patients in clinic moan if they see more than 8. Because they haven't got time. So we really truly understood the pressure they were under. So it might be that we went back to those patients, but the whole ethos was that they would be identified early. I had every patient flashing their legs at me. Let me look at your legs. They're going in to do eye drops, or they're going in to do a B12. Let me look at your legs. You want to look at my legs? Yeah, I want to look at your legs. Let me see your legs. Trying to get people, like you do with pressure ulcer prevention, look at patients' legs, because they will leak, they will grow, because their patients are moving less. So challenge practice, look at what practice, what the management there was, but also a really important part was the reflection. Having somebody with you who could ask you about what management you were doing and reflect with you and try and change practice from an evidence base. So what happened? Well, we saw a whole host of legs, as you can imagine. The complex legs, they wanted us to go and see straight away. Straight away, they could think of patients that they needed us to see with them. But the care was very much reactive, not proactive. Mopping up. And there was this whole thing around the Doppler. We can't do anything because we can't get a Doppler, or we're waiting for a Doppler, or the patient's leg's too big and we can't get a Doppler, and we haven't got a toe pressure machine, so we're waiting for someone with a toe pressure machine to come and do something. So what do you think the management was in that time? A pad and a yellow line, blue if they were lucky, very unusual to have blue, mostly yellow, sometimes beige. So our intervention was to actively treat those patients. Why are they doing the same thing if it's not improving? Reflect on your practice. We delivered the accredited learning over a lunchtime with them, a couple of hours, 1 hour session. We did the video prescription, but we challenged evidence-based care. We had opposition to change. We can't do that. It's okay for you to do that, but I can't do that because I haven't had a Doppler. I said, well, I still want to keep my NMC qualification. I want to finish my mortgage. You know, I'm assessing the patient holistically. I'm putting reduced compression on just to see if we can try and manage this in a staged process. So we didn't go into this process to develop a pathway, but we recognized the need. So the output of this project was that we developed a pathway. So the results. Don't worry about that slide, it's very busy. Just tells you where we've been, who we saw, and what we did. So the patients that were referred to lymphedema, the nurses we worked with, how many did the accredited education, and we also did well-being sessions for the nurses, because these nurses are working extremely hard, like I said, 14 calls a day. And we felt like, because they'd allowed us to do this project, so the well-being was, look after yourself. You're going to be working till you're 80, probably the way things are going. Look after your legs, because, you know, none of you need to come to clinic either. So it was giving something back to them, making them feel valued. So the patients we saw, the patients that we referred to lymphedema, the number of nurses we worked with, all these slides are available to you on the website, so I don't tend to do death by PowerPoint. And then the amount of people that did the well-being session. So what bands did we work with? Well, it isn't a surprise that majority of them were band 5. The total nurses we worked with is 130. We also went out with healthcare support workers because I do believe that there is a place for delegation, but we can't delegate until the qualified staff are competent and they can competently delegate. So there's some work to do. Okay, so what did we see? This is very similar to Christine Moffat's work. I don't know if you've seen that, but it's worth looking at that. 55% of the patients that we saw had some type of swelling. Now, you can see complexities 21. Straight away, the nurses knew who those were, the severe. But the issue for me was the mild to moderates. They recognised that there was edema there, but nothing was happening with them. So this Legs Matter campaign is essential. So for me, it's about identifying that those patients are at risk, so intervene early. The amount of patients that had cellulitis, so we know if a patient has edema, then they're high risk of cellulitis, they have superficial wounds, they're high risk of cellulitis, they're leaking. So there was a percentage, and this again is similar to Christine Moffat's work. The increase to the lymphedema service, yes, we raise awareness, we become the secret of our own success. The lymphedema service based in the health board weren't that too pleased with us, but having said that, these patients were treated at that point. So they were already being managed by the time they were picked up by the lymphedema service. So it wasn't like having a new referral and having to sort that out. We'd already started treatment. The results. For me, the NHS is our NHS. It's our money. We'll all need it. If we haven't used it yet, we might have to use it. We have to value it, and we have to value the money like when we do our own shopping, okay? So for me, there's no excuse for waste or inappropriate use. District nurses, commissioners, politicians, even health boards aren't really interested because the district nurse is employed. So they can do 14 calls a day if they like, doing whatever they like. But I care about that. I care about that massively because they should be spending their time on the complexities like the palliative and all those patients, not mopping up legs. So the district nurse visits reduced significantly. There's p-values after this, but this just shows you the cost savings. You need to remember that this is only over 3 months. So it is a massive spend to save initiative as far as I'm concerned, to have an educator based within communities. The dressings, people care about that. If you can save money on dressings, you hit the pharmacists, the medicine managements. So we're looking at transformational care and whether we can do a spend to save project on from this. And cellulitis, hospital days, those are the kind of things that people sit up and listen to. But for me, the district nurses is as important, if not more. So there's your p-values for you. Like I say, just reducing. So it's not about you need less nurses, it's about putting time back to care. It's about nurses doing what is essentially they need to do, and there's a benefit from that. Quality of life. We collected quality of life data. Again, you can see the right things go up, the right things go down, and then you can see the percentages around health economics with the reductions. This is a busy slide, but it just shows the dressings reducing when we were there, and funnily enough, going back up when we left. That brings me on to how we sustain the change. That's another challenge. I truly believe that education doesn't change practice. Education plants a seed which allows you to reflect, and sometimes having somebody with you who instills the confidence for you to change and then become competent to change is the way that we should be transforming NHS. So not sending people on education courses, however, bringing them together. So yes, have the theory and the education, but develop the skills through good leadership and working with specialities. So allowing those specialists not to become specialist nurse, but sharing. So I think specialist nurse role is more of a leadership and education and allowing generalists to be upskilled. Because otherwise, what we tend to find is we strip the skills away from everybody and then they don't feel empowered to do that. So the pathway, like I say, everybody talked about guidelines and pathways yesterday, and sometimes it restricts your practice. We didn't go into this project to develop a pathway. It was clearly identified that to try and initiate a change of practice, there needed to be a pathway that nurses felt comfortable to follow. So we looked at the evidence to see what was out there, and there wasn't much. So it isn't just a pathway, it's a document with the evidence to support the pathway. We're not precious of this pathway. I believe it will go on the BLS eventually. Yeah. I am happy to share it with whoever. If it helps to change your practice, I've done a generic pathway. There's a pathway within this document which is obviously to Wales, but it's very easy to change that, and I've changed it so that you can use it anywhere. And it's been taken up by people in Ireland, Canada, I'm trying to think where else. England, in some areas in England. So why do we need it? Because we're spending a whole lot of money on dressings, leg ulcer management. Care is reactive, not proactive. When nurses say to me they have a little bit of edema, I feel my head doing a full turn, spin. It's a bit like the Doppler. I'm like the exorcist. My head's going to spin round now. Calm down, Karen, calm down. A little bit of edema is like telling me someone's got a little bit of diabetes. Let's not bother. Let's hang on a bit and see what happens. I'll tell you what's going to happen. It's going to get worse. So don't tell me they've got a little bit of edema. Do something about it. Okay, so there we are. I'm better now. I've got that off my chest. So it's vital that we implement prompt management to reduce escalating costs. We've got to do something. We have to do something. So how do we influence change? We educate, we rationalise. There's a missing link though. So the evidence-based the guidelines is evidence-based. We did a literature review. We have documents and guidelines, protocols supporting the pathway. So this is the pathway, and we all like a little pathway. It tells us what to do. If something's not right, we go down that pathway. But what's nice about this is, and hopefully it will empower people to feel confident to start some lower compression and support to try and mop up these legs. Does it work? Yes, it does. Does it reduce calls? Yes, it does. So really, I think people should be challenged if they're not doing it, because it's evidence-based. So the level 1 support, it's not rocket science. I can't believe nobody's ever thought of it. I'm quite happy that we did it, because it's quite nice to have a pathway with your name on it. However, that doesn't impress me unless we influence a change in practice. What impresses me is when a patient's story is that they were mopped up a lot quicker. I often use the analogy that my son is a plumber. I know it's very exciting, but he can never do any work for me because he's far too busy. However, if I have a leak under my sink, I have 40 lovely towels, so I'll use them. And I'll keep washing them and putting the towels down. I'll keep washing them instead of having the valve fixed. Why would I do that? Why would I not pay someone to change the valve and stop the leak under the sink? It's exactly the same. Unless you reabsorb that tissue and compress that leg and manage that leg, it's going to carry on leaking. And then they might have cellulitis, and then they might have a wound, and then they might have a complex wound. So we need to think about that. We need to be proactive. So level 1 is no compression. It is a yellow line, 3 rolls of padding, and another yellow line. That can be used palliatively. It can be used on any patient. It can increase their comfort, and it can reduce district nurse calls. Rather than just putting a pad and a liner and go in there every day, you can reduce your calls down. 1 layer of a short stretch bandage is level 2, and 2 layers of a short stretch bandage is level 3. We also did a management plan or a care plan, so you can move from one level to the next if you feel confident. The most important thing to remember is that you refer to a lymphedema service when you start the management. I believe that we need to look at delegation. The King's Fund suggests that we have a greater skill mix within teams, and delegating tasks to healthcare support workers has the potential to enable senior staff to deliver care for patients with advanced or complex needs. In all our lymphedema services in Wales, we have healthcare support workers that are delegated a course of bandaging for a specific patient. But we're not there yet in the community because we have to have competent, qualified staff first. But I think that we need to think about things like that, otherwise we are going to drown. So, dissemination. Anybody can have it. We put a business case in to upscale the project to another 2 health boards. With all that evidence, with the focus groups, the nurses wanted it, they valued the support, and the Health Technology Fund told us no. My head did a little spin then at that point. I had a cup of coffee, sat down, took a deep breath, thought, how can you say no to me when we've given you health economics, quality of life, focus groups? Why they said no, and I understand it completely now, is there's no sustainability, which we see. The health board that we worked in, although the pathway's there, nurses resort back to historical practice, and I don't know why, but I think to solve that, what the Health Technology Fund told us was, if the health board sustain a post at the end of it, we'll give them the money with the influx at the beginning. And I get that, it's our money. The health board should step up and say, this is a new way of supporting nurses, this is a new way of delivering education. You as a health board need to say, yes, we'll have a post. We have district nurse vacancies all over the place. This would support district nurses in their role in a really good, effective way, leading people to be autonomous and challenge their practice. So I retire in about 5.5 years. I know I don't look old enough, but that's the way it is. And when I go, my boss doesn't think I'm going to go, but I am going to go. When I go, I hope that there will be an on-the-ground educator in each health board. I'm somebody who doesn't take no easily. You might have got that from me. Those who know me know that that is the case. When I know passionately that it makes a difference. So watch this space. We've published because the evidence needs to get out there. So if, like I say, this is available on the website. If anybody needs any information from me after, then please come and see me, or my email's at the very bottom if you can write it quick. So thanks to the Welsh Government Health Technology Fund for supporting it. The other thing, just to say very quickly, is you have to be innovative about education. And what I've done on the back of this is created a video, which is a pocket medic video, which is actually the wet leg pathway being performed on a patient with toe bandaging. So that's a way of getting that out as an education and a supportive way of supporting staff to revisit it and look at it. With an actual patient whose story we used in the beginning. He was leaking for quite a period of time. I'll just tell you, am I right just to say this very quickly? Okay, so he had a bilateral arm amputee. He was electrocuted. He was 50. He was buying his own dressings. His legs were leaking. We used him as his patient story. We bandaged him for 2.5 weeks. We got him in a flat knit garment. We reviewed him, and I asked him if he would be involved in me making the new video, because I thought it was nice to have his story and then him as the same patient. He's actually in a circular knit off the shelf now, and his legs are amazing. And in the video, it demonstrates where he was and where he is. So although people could challenge that they revert back to practice and the changes aren't sustainable, for him, he's 18 months dry and with quite small legs and looking a whole lot better. So I would argue that, yeah, it does make a difference. Thank you very much.